AMC Cardiology Part 2, but this is more of some vascular parts that I left behind from cardiology. So when we take cardiology, vascular plays a very important role. It's like a mixture of surgery and cardiology for me. I don't know. So I kind of study these sections when I do surgery as well, but then I thought I should go through these parts so that it'll be easier for you all to do the cardiovascular Amadex questions. So these are the topics that I thought I will discuss. Oh, my bad, I'm sorry, but this peripheral arterial disease has, it's not the topic. These are the ones that I'm going to talk. So it'll be aortic aneurysm, peripheral arterial disease, deep vein thrombosis, pulmonary embolism, a very controversial topic when it comes to AMC. So many opinions and so many guidelines say different things. So that's that. And actually, these varicose veins and carotid artery disease are not it's not something that you have to know very deep into, but we can brush it through. I think I had a little guideline at the end. If I am able to cover all this, I'll discuss about that as well. Carotid artery disease is something that I studied in neurology, but let's see if I have time, I'll try to talk about that as well. But I feel like I should leave it for neurology. So let's get into the discussion. So I want to say that I took all these details from guidelines today. So something I also want you all to know is that when it comes to AMC, the resource, like, I don't know, for me personally, I realized it while doing questions, the resource kept changing. Like some areas I would die hard be following John Mutaj, and some parts just guidelines, and I would just remember which guideline to go to. And then there were some parts that I would prefer certain websites, likewise. So I had segments. So this vascular part was really supported from guidelines. So I followed guidelines in this. So as you all know, aneurysm means it's like a segment of an artery that has expanded to more than 1.5 times of its normal diameter. So in Australia, this abdominal aortic aneurysm, AAA, abdominal aortic aneurysm, it's very common in older men. That's something you should know. So if the question is directing to older men, you should know. And about 4 to 7% of men over 65, let's say, yeah, over 65, and about 1 to 2 percent of women will have some dilation of their aorta. So that's like their prevalence. And these risk factors, I straight away got a screenshot from the guidelines. So it's pretty much mirroring the risk factors of atherosclerotic disease. So it's like increased age, male gender, smoking, family history, atherosclerotic, of course, and hypertension, high cholesterol, and then also other vascular aneurysms. And also another thing we could add is, oh yeah, family history. Family history is there as well. So I think it's very important for us to remember these risk factors, because AMC questions definitely, like, they somehow pop in a little risk factor inside the question stem. Uh, and we would just not focus on that because we are so focused on the clinical features and the investigations what the patient has done. But then to see there's like a very obvious risk factor in the stem. So all these, it's good to know risk factors in these sort of diseases, especially these aortic aneurysm. So let's get into the next slide. Okay, so this table also this table also I got it from the guidelines. So for this abdominal aortic aneurysm, I followed RACGP guidelines from 2013 or something. Just let me confirm. Yeah, this is the guideline I followed. So as you can see, what I did was I just typed aortic aneurysm, RACGP, and I went through the first few options that came, and I found out an article that can cover most of the areas I should know for the exam, and I would like make my note out of it. So that's, I mean, I don't have to do that. You could also do it by your own. So just always keep guidelines in hand, closer to you, so you can always make sure you're relying on a very reliable source actually. So this is the guideline. I hope you all can see the screen when I switch from the presentation slides to this Google page. If y'all can't see, please let me know. So right now I have opened the guidelines on Google, where I have typed RACGP aortic aneurysms, and this is the article that I followed. So I will try and copy paste this link for you all as well, so you all can do some extra reading. You all can open these tabs and keep in your phones or laptops or whatever the devices you all are using to join this meeting. And yep, so I've just sent it on the chat. So this is basically what I followed. You all can have a read through. It's like a shortened version of this article, what I'm reading. So just remember that small aneurysms, which we call like under 5, let me just, yeah, 5.5 centimeters, under 5.5 centimeters, they grow slowly. So maybe like 2 to 3 millimeters every year. But also remember, as size increases, so does the growth rate and the rupture risk. So remember like that. Larger ones expand faster and smaller ones, they expand like 2 to 3 millimeters per year. And then this chart is very important to know. So just remember that, just how I roughly remember, it was like below 4 centimeters, the rupture risk is negligible. It's 0%. And then between 4 to 5, there's like a 1% risk per year. This is per year risk. And then once the aneurysm crosses 5.5, that is when we call a large one, the risk shoots up. So it could even like go up to 10%, somewhere between 1 to 10%, like now up to 20% per year. So that is like a rough way to remember this chart, with its what do you call, the risk of rupturing per year, percentage per year. So that is something that you will have to remember. And the last thing is, just remember, if it's more than 7, half of them will rupture within a year, 50%. Just remember, half of them will rupture. So below 4, it's negligible. Between 4 to 5, just remember it could be 1 to 10. And more than 5, remember we said 5.5 is, more than 5.5 is large, so more than 5, it could be around 10 to 20%. And anything more than 7 centimeters, half of them could rupture within a year. So just remember it roughly like that, because there's a lot of numbers in AMC and there's no way we are going to remember everything in detail. So it's like keep short methods to remember those, add them in your notes. So yeah, and then something that you have to remember is when the rupture occurs, the mortality goes really high, like even up to 80 to 90%. Even if you've done surgery, the mortality rate is very, very high. So this is why this topic is very important for us to know. This is why AMC has been testing this a lot. It's very important to detect and monitor before it gets to that rupturing point. So yeah, let's go to the next slide. If you all have any questions, please feel free to ask on the group chat. You all, I mean, it's okay if you all don't unmute and ask questions, but then if there's anything that's doubtful along the way, ask on the chat. Let's figure it out together. Let's search it up. If it's not clear enough, let's look for more guidelines and all that. So we'll figure it out and go along the way. So now let's talk about the screening and surveillance and imaging. Now, I know I said the previous table was very important, but I feel like this is the most important one. I'm sorry I had to say that. I'm saying every table is important, but this table, if you've done Amadex, you must have realized they would just throw out numbers right away at us and expect us to know the months. So this table is like golden for AMC. I'm pretty sure every month this table would come in use. So one thing that you should know is that there is no like a formal national screening program for abdominal aortic aneurysm, but there's ultrasound screening for men 65 years or more. So, I mean, this ultrasound screening of men aged 65 years or more, it has reduced the aneurysm related mortality. So always know that, okay, so this is a very important point. Imaging. Ultrasound is the first line for screening when it comes to abdominal aortic aneurysm. I think I mentioned it in the previous lecture as well, that it is very, very important for us to know in AMC about this first line, gold standard, next step, best step. Those words are the ones that are like literally fooling around with us. So be very mindful what they're asking. So if they're asking what is the first line, these are words straight out of the guidelines. So be very mindful. Imaging, ultrasound is the first line for screening. And AMC is definitely going to put a CT angiography along the answers to mess us up. So just remember, ultrasound is the first line for screening and surveillance. CT angiography is for pre-operative assessment. That is something you should really, really know when it comes to abdominal aortic aneurysm. So, what we have to know about this is that, yeah, so this table, I'm really sorry to say this, but it is something to memorize. So, directly memorize 3 to 3.9 every 2 years. And if your aneurysm is 4 to 4.5, it's 12 monthly, that is 1 yearly. And if it's 4.6 to 5, you got to follow up it every 6 months. And then if it's more than 5, you do it 3 months. So this is very, very, very important. And yeah, that's something you got to know. Now let's talk about when should we refer for surgery. So according to these RACGP guidelines, men with aneurysm greater than 5.5 centimeters, or women with aneurysm greater than 5. This is also a very important place where a lot of questions have come. They should be referred for surgical assessment. And any aneurysm that's growing more than 1 centimeter per year or causing pain, like symptomatic, literally. That's like causing pain or tenderness or anything, any symptoms, they also need urgent referrals. So these are at high risk of rupture. So what we would do is, when it comes to, just remember the indications for the surgical referral, the surgical repair. These four are the ones that you should remember. So when it comes to management, it's easier to remember to divide it into two, small ones and larger ones. I would just remember the number 5 around when it comes to aneurysms, because I came across that a lot, because when it comes to surgical indications, there's 5 here again, and then up here there was 5 again. So we would rather call 5 as a turning point for small and large. So when it comes to small abdominal aortic aneurysm, we could just do surveillance, do screening, and then manage the cardiovascular risk. Uh, what we would usually do, like, you could just do strict blood pressure control, maybe give statins or smoking cessation or antiplatelet therapy. We would just, for asymptomatic small aneurysms, we would mainly just remember that you try to control the cardiovascular risk factors. And for large ones and symptomatic ones, we talked about the symptoms here: abdominal pain, back pain, tenderness, and all that. So, symptomatic and large ones, you could go for open repair, it should be or could go for uh, endovascular stent graft. It's actually, the choice is, it depends on the patient's fitness and anatomical um, suitability of the location of the aneurysm. So you could either go for, just remember, surgery for large or symptomatic ones. That's basically this one, what this says. So that is that. Just remember the centimeter amount for men and women, because that is very, very, very important. There was once this question that directly asked these, among the questions, the question was like, what wouldn't be a indication, or when wouldn't we go for surgery? And this was, I think, they messed it up, like they jumbled it and it gave, and it was so confusing at that moment. So it's very important to know this one. Now, that is that about surgical referral and a rough management plan for abdominal aortic aneurysm. So yeah, when it comes to abdominal aortic aneurysm, what we would want to know for AMC is that it's a very silent killing disease of old male smokers. So just remember those days, old male smokers. And also remember that size is everything when it comes to this. So larger it is, the higher the rupture risk. So aneurysm size is like the major determinant for rupture risk. Just remember those tables that we just discussed. And also remember, AMC is very fond of asking questions like, is there any screening program in Australia? But no, there is no routine screening, but high risk patients should be considered. We also talked about their monthly surveillance programs in if they have risks and if they have any aneurysm already diagnosed. And those intervals also, it varies according to the diameter. That was that table, which had 3 to 3.9, 4 to 4.5. Likewise, that table was that. So the other thing that we should also know is that small abdominal aortic aneurysms, what we do is we optimize the cardiovascular risk factors. We just spoke about it. We would just managing blood pressure, managing lipids, advising to stop smoking, and all of that would be for small and asymptomatic. Just remember asymptomatic as well. So asymptomatic ones, we would control the cardiovascular risk factors. And when it comes to large and symptomatic ones, we would just go for surgical referral. For that, just remember those 4 points that we just discussed above here. Male with more than 5.5 centimeters, female with more than 5, and rapid growth more than 1 centimeter per year, and symptomatic. Those are the ones we should know. And we also discussed that for imaging, ultrasound is like the first line one for screening, monitoring, and everything. And we go for CT for surgical planning. So if you simply study or read or just go through anything regarding any topic that you are planning to study for AMC and just write down the important points like that, more than making pages and pages of notes, I mean, you should be good to go for your questions. I mean, it would be really helpful for your questions because you basically have all those slides summarized over here. So just try to make notes like that when you're doing. I mean, it's not that when you have like 2, 3 weeks for your exam, you're going to be reading pages to find like a small answer. So it's always best to make it short and point it out as shorter, like as summarized as possible. So try to do that. So that was pretty much it about aortic aneurysm. All of that was taken from the guidelines which I shared on the chat. There's so much more to read in it, like if you can try to do that. But I tried to make it, I tried to limit to a range where I thought AMC would ask, as in of questions that I came across for AMC preparation. So if you, I mean, feel free to read if you haven't booked your exam yet, and if you have time, try to read all of this. I mean, it's good to know, but AMC is pretty focused, like question focused. So, and if you're running out of time, it's good to just follow these. So if you want, you can take screenshots or just take screenshots of the link I shared. And yeah, let's go to the next topic for the day. Oh yeah, before that, I have added just 1 or 2 questions just to make you all get an idea about how questions appear related to aortic aneurysm. So let's try and do this one. A 68-year-old man who has smoked 1 pack per day for 40 years attends for a routine health check. He is asymptomatic and has well-controlled hypertension. On examination, on abdominal examination, a pulsatile mass is felt. An abdominal ultrasound shows an infrarenal aortic diameter of 4.4 centimeters. So this is why I said it's very important to know the table. They would just directly give you the numbers. Which one of the following is the most appropriate next step in management? Immediate referral for surgical repair, repeat ultrasound in 6 months, repeat ultrasound in 12 months, CT angiography of the abdomen now, commence high dose of beta blocker therapy. So try to find the very important points in this question. And if y'all could, it'll be so great if y'all could just drop in the answer that y'all think is right of after what we just discussed. Let's see. Yeah, okay, that's right. So you already have an answer saying C on the chat. So let's check it. And that's absolutely right. So that's what I'm saying. Like guidelines, you could just directly answer stuff out of guidelines. So the answer is C. Obviously, you don't have to think a lot deep in this question. So this was actually a recall question. So I'm not 100% sure if all the little STEM parts were there. So recalls are basically what those exam candidates go to their exams and they just come back and share whatever they remember on group chats and on whatsoever the study groups they've made. So this was a recall question that I just adjusted from here and there to get it properly sorted. But maybe it had more details. Maybe the stem was longer than that. But as you can see, the base of this question, we wouldn't even need 1 minute or 60 seconds to do this question. So we could save it for a long, a complex question. So that's why it's very important if you remember that table on the exam day. Would have saved so much time for you. So that's right. The correct answer is C, to repeat ultrasound in 12 months. So the explanation is obvious according to the guidelines that we just read now. An aneurysm measuring 4 to 4.5 should be monitored 12 months, every 12 months with an ultrasound. So it is just this table, just this table. So 4 to 4, yeah. Okay, that should be every 12 months. And surgical repair is only indicated when the diameter exceeds 5.5. That's for men, don't forget that. And yeah, and 5.0 for women. Or if the aneurysm is symptomatic, or if it's expanding 1 centimeter per year. We just discussed all of that. And we also discussed that CT angiography is reserved for pre-operative planning. It's not the routine screening method. For routine screening, what did we do? For routine screening, we just discussed a little while ago. So for routine screening, we did ultrasound, right? So obviously CT is not the answer. And beta blockers, they are not an indicated drug for to prevent abdominal aortic aneurysm expansion. So it's very, very important to know these surveillance intervals, like I said, and the referral thresholds, as in this little table over here. It's very important. Just answer that question out of those two tables. There's nothing big in that. So yeah, it should be C, repeat ultrasound in 12 months. Now we go to this question. 74-year-old man with a history of hypertension and hyperlipidemia presents to the emergency department with a sudden onset, severe abdominal and back pain. He looks pale, diaphoretic, and blood pressure is 80 by 50, which is a low blood pressure, and pulse is 120. And oxygen saturation is 93% on room air. Examination reveals a pulsatile abdominal mass. Which of the following is the most appropriate next step in management? So they're asking the most appropriate next step in management. Order an urgent CT angiogram to confirm the diagnosis. Begin large volume fluid resuscitation to restore normal tension. Arrange immediate transit to theatre for surgical repair. Start intravenous labetalol to control blood pressure. Give high flow oxygen and wait for imaging. What would the answer be? Just be mindful of all the details that's given in the questions, Tim. And what do you think the answer would be? Okay, let's see. We also have a few questions, answers given. So I would just my eyes would directly go to these symptoms and the fact that this patient is very symptomatic. For me, it would directly indicate surgery. So let's see. Oh, yes. So the answer is arrange immediate transfer to theater for surgical repair. So this patient, we just talked in the previous slides how scary, like how high the mortality rates are of a ruptured abdominal aortic aneurysm, right? So it's basically a surgical emergency. So this patient clearly has a ruptured abdominal aortic aneurysm, and that classic symptoms are there: the abdominal pain, the hypotension, the pulsatile mass. So I don't think we should be sending this patient for any imaging or any other to confirm the diagnosis or anything. I think this patient has to be undergoing surgery immediately. This is a direct surgical indication. This patient has surgical indications, right? So you shouldn't be delaying management like imaging and all that uh, without going for surgery. And um, yeah, that other thing is we have to. This is just not only for um, aneurysms. This question has popped. This theory has popped up in many other segments I've seen. CT angiography is appropriate only in hemodynamically stable patients. Do you think this patient is hemodynamically stable? I discussed this last Tuesday in the cardiology part 1 class. We would just remember things like hemodynamically stable patient and hemodynamically unstable patient, but we would always forget to know what is hemodynamically unstable. We would just ignore all the vitals given, right? So always check the vitals. It's very important. So this patient is not a stable patient, so we can't go for any imaging and all that. And the best thing would be to direct this patient for surgery. And yeah, it's definitely unnecessary to do imaging in an unstable patient. A rapid surgical referral should be the answer. So the most promising answer out of these would be arranging an immediate transfer to the theater for surgical repair. So yeah, this is what AMC does to us. They give answers that, I mean, like, they make most of the answers, at least three of the answers out of the five given, sound like absolutely right. I mean, they would be right answers, but they're asking in a critical situation, in a decision making situation, what would be the first thing? What would be the next step? Not the most appropriate next step they're asking. So we have to always go think that way and go for the most promising one, most guideline supported answer. So according to guidelines, going for surgical repair would be the answer. So I hope you all got like a basic idea of abdominal aortic aneurysm. Uh, Obviously, there definitely should be more to read about that. So try to read from the guideline that I shared on the chat. And yeah, let's try to go to our next little subtopic. Uh, yeah, I would like to talk about acute limb ischemia next. And this one, I've taken it from Australian Emergency Care Institute clinical guidelines. It's a very newly updated one. It's from 2025. So I'll just roughly show you the article as well, and I think it's better if I share it to you on the chat as well. So this is the one I followed. It's a pretty good article to read. It's very short and nice. So, and just know that this Emergency Care Institute also has so many other little topics that you could read. I think this is a good website to read things. So I'll just share it. Just keep these tabs open in your phone or device. It will come in handy. So what I would do is just screenshot most of them. So yes, let's talk about acute limb ischemia. This is also a little heading towards surgery, but I would also find these questions in the cardiology section in Amadex and the handbook. So that's why I just wanted to cover it for you. So acute limb ischemia, so it is a surgical emergency in, of course. It is like a sudden drop in arterial blood flow to a limb that could threaten its viability. So this emergency care institution, they define an acute limb ischemia as a loss of perfusion within 14 days. That's how we define the acute one, which is basically 2 weeks. And if the symptoms last longer than 2 weeks, we classify it as a chronic limb ischemia. So, one of the main causes that you should remember is thrombosis, embolism, and this is not very common, but it's like a less common cause, arterial dissection as well. And it's a very time critical condition, and there can be like irreversible nerve and muscle damage. It could occur in like 4 to 6 hours. So I feel like if you see any acutely cold or painful or pulses, we'll get there, we'll get to the symptoms. Limb, you got to act immediately. Just remember, in situations like that, in this, time equals tissue. So you must be already knowing this. So it's very important to act fast. So let's get to the detailed areas of this topic. Now, first, talking about the causes and the risk factors. It's more like acute limb ischemia is most commonly caused by an embolus or thrombosis. So just know that an embolus often it originates from the heart, especially in patients with atrial fibrillation or a patient who had a recent myocardial infarction. So an embolus is basically a dislodged clot that travels and blocks a peripheral artery. Very common, something that we should know is very common in femoral and popliteal. It's very common there. So that is that. And thrombosis, on the other hand, happens when a pre-existing plaque or a bypass graft suddenly clots off. So that's that. Those are the two main causes for acute limb ischemia. And then we also have like a other less common cause, like it's less frequent, obviously. Causes like arterial trauma, aortic dissection, and yeah, DVT with paradoxical embolism. So those are not very important. It's good to know these two. And just know that the key risk factors would be atrial fibrillation, having a recent MI, aortic aneurysm, or peripheral vascular disease, smoking, just like we discussed, all of that. And one thing we should really, really remember is that when you suspect acute limb ischemia, always consider cardiac sources. And it's always better to do an ECG to check for atrial fibrillation. It's very important, ECG. I should have written that here. So ECG is a very important point. So yeah, let's get going. Okay, so this is a classic thing that most of you all must be already knowing. The clinical presentation, the 6Ps, the classical presentation, that's how we all remember it. Pain, pallor, pulselessness, perishing cold, paresthesia, and paralysis. So with that being said, I would also like to point out that pain is the earliest. Pain is the earliest and I would say the most consistent. Pain is the most earliest and most consistent sign. Like usually the pain is like, you must be already knowing this sudden and severe and it's like out of proportion. So yeah, that's a very early consistent sign. And then this pallor and coldness would be due to loss of perfusion, and paresthesia and paralysis are late features. These are late features. And I mean, those things, they indicate that the limb is already threatened. That's something that we should know. Paresthesia and paralysis. If you are already having those symptoms, that means the limb is already threatened. I mean, we would need urgent revascularization. That would be the only way to save it. So those are some of the things that you should remember. Yeah, and just remember, an embolic event would cause like a sudden, like a dramatic onset in a previously normal limb. Just remember that embolic. If the cause is an embolic cause, it would be like rapid onset, so like a sudden dramatic one on a previously normal limb. Whereas if it's thrombosis, if it's a thrombotic occlusion, it's more gradual. It's like often in someone with pre-existing peripheral arterial disease. So you would see like gradual onset if in cases like that. So that is also a very important thing to remember. These are like little things that I came across when going through the guidelines. So just remember these points. Yeah, that should be pretty much it about the clinical presentation. We talked about the 6Ps, we talked about the earliest sign, the late signs, and if those signs are there, it would be threatened limb. And yeah, how to recognize from the onset, the clinical onset. Yeah, that should be it. And let's go to the next slide. Meanwhile, I'm just repeating myself. If you all have any questions along the way, please feel free to ask on the chat. We'll try to go to the initial guideline, which I got all these resources from, and try to read it through and find try to clear our doubts. So once you identify a potential case of acute limb ischemia, I would say the first step is resuscitation. First thing you got to do is resuscitate. So simply you got to correct the hypotension, give oxygen, you establish IV access. Just keep your mind, the first thing is the resuscitation. And you got to document all peripheral pulses carefully. And there's a grading system. Some of y'all may already know that, but I am sorry I couldn't add that to this slide. But what I'll do is I'll go back to the guidelines and just show it to you all from there. Should be in guidelines. I remember seeing it somewhere. Yes. So this is the grading for peripheral pulse. This is how peripheral pulse should be examined and documented. Uh, the grading is done due to its intensity. So 0 means no palpable pulse. 1 plus is a faint, like but a detectable pulse. 2 plus means it's diminished pulse, and 3 would be normal pulse, and a 4 would be a bounding pulse. So this is a very important point. I would say I would have added this to the note. It's good to know. So let me get back to the note. So yeah, so our second thing to do would be carefully document the pulse and grade them. And yeah, and what we could do is use a Doppler if they're not palpable. So that would be that. And it's also important to check for thrills and brutes to see if anything is suggesting a chronic arterial disease. That's important as well. And we would do an ECG, like I mentioned before. Why would that be? That is to look for any atrial fibrillation. And then we would just send the baseline bloods like the usuals. And we obviously keep the patient nil by mouth in the preparation for surgery. And we would give adequate analgesia, and we would notify the vascular surgery early. So it's always good to act as if, I mean, it's good to know that this delaying would cost this limb. So think of that way and try to act. So that would give you these steps. This is pretty much what I found from the RSHEP guidelines. This is a summarized version, so if you all can try and take a screenshot or try to read it and make your own notes, and you all would also come up to a summarization like this probably. So that would be like the initial assessment, and this is something we also need to know, because when it comes to questions, the findings are the ones they would give. So it's really, really important to know the category in order to know what the management would be. So this table, I would say, is very important, and it's good to know it by heart. I just turned it to a table. It was actually in the guidelines as this. Viable, marginally threatened, immediately threatened, reversible, and as such. So the management obviously depended on that. So we'll quickly go through that. The viable limb, no sensory motor loss, and through Doppler it's audible. So what we would need in patients like this would there's nothing like what we would need in these patients is like, I would say, an imaging and got to work up, but this wouldn't indicate an immediate surgery, so we are still good to go. And then marginally threatened would be minimal sensory loss. So minimal sensory loss, and Doppler may be inaudible. It's like, say, often inaudible. And these ones, they would require revascularization. So just remember these findings. That will help you to find out what the management would be. And the next one we have is immediately threatened. Immediately threatened limbs would be significant, like a sensory loss and some weakness. And the Doppler would be silent, inaudible. These might need a immediate revascularization. This is the difference. So this would need a revascularization. This would go for immediate revascularization. And then we also have at last irreversible limbs where complete anesthesia, like completely lost, and no Doppler, obviously inaudible. And this sort will not recover and would have to go for amputation. Just check that. Yeah, I think it's better to read that part from this link which I just shared. My table is quite too summarized as my understanding, so it's good if you all can read this part or take a screenshot of it now and know the managements that way. So it should be that. Yeah. So it's very important to know these sort of tables, like classifications for AMC, because it's about like the whole management depends on the classification. So it's very important to know it. And yeah, let's go to the next slide. Okay. So next we are going to talk about the imaging and definitive management. So what I would remember is once the patient is stabilized and the vascular surgeon is involved, we can go for imaging options like triplex ultrasound, then CT angiography, and go for intraoperative angiography. Just remember from the above chart that you should not delay revascularization for threatened limbs. Threatened limbs, you shouldn't delay revascularization. And you should, like, this is the emergency department management, you should start unfractionated heparin immediately in the emergency department unless contraindicated, because it could prevent the progression of the thrombus and allow time for surgical intervention. So it's very important to know this heparin. It would prevent the propagation. So heparin is very, very, very important and a crucial drug in this condition. And obviously, you've got to prepare the patient for the surgical interventions. And the definitive options would be embolectomy. You could either go open or catheter based for embolic occlusion, that is. And then you would go for a bypass surgery for thrombotic diseases. And there's catheter-directed thrombolysis. I'm sure this is pretty explained in the guidelines. I'm just going through these. And like we discussed, if it's a irreversible limb, we would go for an amputation. So yeah, those are the definitive management options and the first steps that we got to do. So it's very, very important to know these things because AMC would direct you all to asking what's the first step, what now we've given heparin, what would we do next, likewise. So it's good to know the order or good to know it as a flow chart or however that's working for you all. So that brings us to the end of our acute limb ischemia topic. Just one of the key points, like I did for aortic aneurysm, I I think it's good to know these things. Good to know it's a vascular emergency. I mean, it's very important to recognize it soon and go for referral. And the 6Ps, classic presentation. Just remember the 6Ps when you hear the name acute limb ischemia, ALI, then 6Ps. Remember it like that. So, and also, I mean, early heparin. You should never delay uh, the definitive management for imaging when the limb is threatened. That's a key point in AMC questions. And I would just say always mention heparin in your answer. It's like the first drug you give in nearly every case. So heparin should be a very safe answer when it comes to this acute limb ischemia, unless it's contraindicated, of course. And I would just say if you can just remember the sequence of like maybe just go recognize, resuscitate, and anticoagulate, and refer, and then revasculate. I mean, it should just cover the order. So, with that being said, oh, also, this is also something that you should know. I came across that towards the end of the article. I mean, after I almost made the note. It's irreversible after 6 hours of ischemia. Just remember that point as well. Add it to your notes. That would come in handy. So, yeah, that's like a very brief cover up for acute limb ischemia. Try to read more from the guidelines. And let's just do this question. So, this is a 70-year-old man with atrial fibrillation, presents with sudden severe pain and pallor, severe left leg pain and pallor. The limb, the foot is cold and pulseless, but has mild toe paresthesia only. What is the most appropriate next step? So the answers are urgent CT angiography, start IV heparin, and call vascular surgery. Begin thrombolysis in the emergency department, observe for 12 hours, immediate amputation. So if y'all could just pop in your answers in the chat, that would be great. So we could just get an idea of how much of an understanding we have. My limb is cold and pulseless. Only is the most appropriate next step. They're asking the next step. Those are the ones that always catch my eye. Like they're asking the next step. So what would it be? I think this answer is pretty straightforward. Yeah, that's right. So we do have an answer. It's B. I would also go for B. Let's see. Yeah, it's B. Start IV heparin and call for vascular surgery, because the stem says mild sensory loss. So because it says mild to paresthesia only, it means it's threatened, but we could do something about it. So immediate IV heparin prevents propagation. We spoke about this earlier. So absolutely the answer should be B. And then we should go for urgent vascular referral, which enables revascularization. So yeah, The immediate anticoagulation should prevent propagation, while the vascular surgeons or the team or whatever prepares for the revascularization of this patient. So answer should be start IV heparin and call vascular surgery. I mean, this is quite easy because AMC would definitely divide this answer into two. I mean, start IV heparin in one and call vascular surgery in the other. That's how confusing AMC answers could be. But then just remember, they're asking for the next step. They're asking for the next step, not the best. So yeah, CT may follow only after consultation if limb remains viable. So yeah, that should be the answer for that question. Now, yeah, let's try to do this one as well. A 63-year-old woman presents 6 hours after sudden right leg pain and numbness. The leg is mottled, cold, insensate up to the knee, and she cannot move her foot. Arterial Doppler is silent. What is the next step? What is the best next step? That's what they're asking. What is the best next step? The answers are continue heparin and order CTA, urgent catheter-directed thrombolysis, immediate surgical embolectomy, proceed to amputation, observe for spontaneous recovery. What would the answer for this be? Now, this is where our table comes in hand. The table of classification where I just said that the management is decided on the type of ischemia, the type of clinical presentation, the classification. So just try to recall it. Exactly. So on the chat we have proceed to amputation. That's absolutely right. It should be proceed to amputation. Why? I mean, there's profound sensory and motor loss, which classifies this as to irreversible ischemia. So this is a very important point over here. There's something we should know. Revascularization risks reperfusion injury and hyperkalemia without benefit. Like if you, I mean, if you're revascularizing a non-viable limb, it risks reperfusion injury and hyperkalemia, and that can often lead to death. So it's very important to make this decision. And this is what AMC does. Like in AMC exams, they'll always test whether you can find the difference between a limb that you can save or not. That is like the key difference between a good and a borderline answer. That's what they would do. So always try to understand the clinicals of this question, understand where this patient stands and what the patient requires. So this is basics as this irreversible limb. There's no sensation, no movement, inaudible Doppler, straight away amputation. So yes, you all got it right. So I hope that little explanation about the limb ischemia and aortic aneurysm was helpful. So let's try to do the other topic as well. So that's deep vein thrombosis. And for this, I got the guidelines from RAC GP clinical guidelines from 2010. I will share the link as well. So deep vein thrombosis is it this? Yeah. Sent you all the link for deep vein thrombosis. So let's do a little discussion on that. It's also a very commonly occurring topic in AMC. So let's have a look at it. So all of you all must be knowing this already. So it's deep vein thrombosis or DVT. It refers to the formation of a blood clot within the deep venous system. It's most commonly in the lower limb. And I would say particularly in the calf and femoral veins. So it also may present alone or as part of a venous thromboembolism. So in Australia, something we should know is that the incidence of DVT is about 52 per 100,000 people per year, that is. That is something good to know. And if untreated, there could be a risk of pulmonary embolism and post-thrombotic syndrome. So those are also some of the complications that we should know that can be very fatal, pulmonary embolism. So that is some of the complications. And yeah, early detection, just like most of the diseases, this also early detection prevents mortality and chronic morbidity. So just is something, I mean, remember that just like aneurysm, this also can be very silent. And also like the symptoms are not very specific, I would say. So we need to kind of have like a very structured diagnostic approach. One of the parts that I've been getting so confused was this deep vein thrombosis diagnostic approach. So I tried my best to put the little the flow chart I found in the guidelines. So let's try to remember that. And when you're doing questions, and if you come across anything that's controversial, then that let's try to find more articles and read through. So, yep, let's get going. This is again directly from the guidelines I took. So, when it comes to the risk factors, it helps us to remember it easily if we divide the risk factors into categories. So, I would say weak, like strong clinical factors, moderate, and weak. I would say strong clinical factors, as remember these, like a fracture of the hip all over limb, very specific about that, the hip all over limb, hip or knee replacement surgery, major general surgery, major trauma, spinal cord injury. I mean, these things, it's so good to remember because I wouldn't ask you all to remember every single detail in the article, but these charts are golden. I mean, these charts are golden. This is directly from the guidelines. So try to take a screenshot and add it to that little folder we discussed last class. So yeah, that is that. And then we could talk about the moderate clinical risk factors, which is arthroscopic knee surgery, hormonal therapy. That is also a very commonly asked segment in AMC, the oral contraceptives, hormone replacement therapy, and all of that. So that also comes under moderate clinical risk. And then we also have pregnancy, postpartum patients, and paralytic stroke, and any patients who've had a previous venous thromboembolism. All of these come under moderate clinical risk factors. So that would be that. And then we also have weak clinical risk factors. So immobilization, basically bed rest more than 3 days, or if the patient has had air travel for more than 8 hours, or if this is a antepartum pregnancy, like pregnancy in antepartum. The moderate risk would be postpartum, this is antepartum, and then obesity and advancing age. So I would say it's good to know these things in order to get your question answered straight away, because these are the ones that they're going to just pop up in your question stem. So it's good to get familiarized with these. So yeah, that's the risk factors that we just discussed. Now let's get to the clinical presentation. Yeah, so I would say, like, the typical symptoms of DVT is unilateral leg swelling and pain, like pain and tenderness, then warmth and erythema of the affected leg. Like those would be the typical symptoms that would pop DVT into my head when I read the question stem. So just get familiarized with these things. And on examination, because MC also gives you examination, sometimes gives you examination findings, there could be like it could be a tender calf, and also like a difference in the calf circumference compared, like, I would say usually like about 3 centimeters more compared to the other leg, increased in calf diameter. And yeah, there would be pitting edema. And you could also see that, like, superficial, very prominent veins, like a dilated superficial veins due to the venous obstruction. So those are the very obvious clinical findings that you would want to remember in DVT. I mean, however, just remember that clinical diagnosis alone is like unreliable, because many of these clinical findings and symptoms overlap with other conditions. So just we would have a lot of differentials like cellulitis, like a ruptured Baker cyst, superficial thrombophlebitis, and lymphoedema. Even congestive heart failure could present like DVT symptoms. So it's very important to know that relying on clinical findings alone can either lead us to overtreatment and unnecessary bleeding risks, like from anticoagulation, or the other thing is it could also lead us to undertreatment, and that could lead the patient into pulmonary embolism. So it's very, very important to know that we can use clinical signs as a guide in DVT, but it's very, very important to confirm DVT with investigations. We definitely have to confirm it objectively. So it's very important when it comes to DVT, because it's mirroring most of the other differentials. So let's get into the diagnostic approach. There was this table and this table and this little chart and all of that. So I tried to make it short, but I don't know whether I failed doing that, because I feel like we'll either way have to come back to this flow chart again. So what we would do, what the RSAGP guidelines recommend is that it's more of a combination. It's like a clinical assessment, and then there's like a testing going on, like D-dimer, and then we do an imaging, we go for compression duplex ultrasound. So it's like a combination of a diagnostic approach in this situation. So in step 1, what we would do is do a clinical, like, assessment, like a clinical, like assessing the clinical probability. For this case, we use the Well score. So That is something we also need to know by heart, the well score. I mean, I'm sorry I couldn't find anything to remember this easily. We really had to remember this by heart. So I would say still read these through. If there's any active cancer or treatment going on, administered within previous 6 months or palliative, you get 1 point. And paresis, or recent plastic immobilization of the lower extremities, you get 1 point. Recently bedridden more than 3 days or major surgery within previous 12 weeks, requiring general or regional anesthesia, you get 1 point. And then localized tenderness along the distribution of the deep venous system, you get 1 point. Swelling of the entire leg, again you get 1 point. Calf swelling more than 3 centimeters larger than the that's what I said earlier, I think. Yeah, more than 3 centimeters. That's one of the examination findings. Remember, it from the well score, so 3 centimeters more than the other one. It's again a point. Pitting edema, confined to the symptomatic leg. If you have pitting edema in the symptomatic leg, it's a point again. Collateral superficial veins, if you can say, that's a point. Previously documented, like previously diagnosed DVT. So yeah, those are the points that we should follow. And if the alternative diagnosis, at least less likely as DVT, you get 2 points. So this is very important to know, because after all, the summary is that if the patient gets 2 points or more, that indicates the probability of DVT is likely. So 2 or more is DVT likely, and a score less than 2 indicates DVT is unlikely. So yeah, and this is another point that the guidelines have mentioned. In patients who have symptoms in both legs, the more symptomatic leg is used when you're assessing clinically. So step one is we would use the well score and assess the clinical probability of that, and we would decide if it's a DVT likely case or an unlikely case. And what we would do is, if DVT is unlikely, if the probability is low, we would do a D-dimer test. And these charts we have to remember by heart. And for that, I would say we had to do as many as questions as possible, because when you do questions is when you come back to this chart. Otherwise, in the middle of the day, you're not going to remember the diagnostic approach chart of DVT. Let me go check that. No way, there's no way that's going to happen. So the more you do questions and the more you mess up, the more you forget. You will be coming back to this chart. So that's the only way to get familiarized with this. So try to do as many as questions. So yeah, where were we? DVT unlikely, we do the D-dimer test. And if the D-dimer is normal, we could safely say DVT is excluded without imaging. We don't have to go to an imaging. But if the D-dimer is positive, if the D-dimer is raised, or if, what we would have to do is go for an ultrasound. And this type of ultrasound is called compression ultrasound scan. So we would do a compression duplex ultrasound. And that would be the next step if D-dimer is high. And in DVT also, you've got to remember that ultrasound is the preferred imaging method, because it has high sensitivity and specificity for DVT. Then what we would do is, if the ultrasound is negative, we would also say that the patient has no DVT. I mean, there was this One place I came across while reading it, if the ultrasound is negative, but the patient is at high risk, we got to repeat it in 5 to 7 days. That was from the guidelines I came across. So, yeah, if the initial ultrasound is negative, but the patient is at high risk, repeat the ultrasound in 5 to 7 days. So, yeah, that is pretty much it. And if it's negative, we go for DVT. And just like that, if from well score the DVT, if we go for DVT likely, what we would do is to straight away go for imaging. And if it's positive, it's DVT, it's diagnosed. And if it's negative, we go for a D-dimer. So if you can see this, what the guideline says is, if DVT is unlikely, D-dimer first, imaging next. If DVT is unlikely, imaging first, D-dimer next. Just remember simple sentence like that, and I'm sure you would be able to get the rest of it right. So yeah, and the rest goes like that. If D-dimer is normal, there's no DVT. And if D-dimer is raised, we would repeat in 1 week. And again, it goes as such. So this chart, unfortunately, is very important and will help you solve a lot of questions. So I would say it's very important to know this chart, try to take a screenshot or try to write it on your own and maybe stick it where you study. It should come in handy when you're doing questions. So that is that. And I also thought I should add this table which said clinical situations rather other than acute venous thromboembolism resulting in raised D-dimer. Like this could potentially diminish the specificity of this D-dimer test. Just know that surgery or trauma can have raised D-dimers, hemorrhage and extensive bruises, ischemic heart disease, cerebrovascular accidents like stroke, infections, malignancy, peripheral arterial disease and aneurysms, pregnancy, advancing age of patients, extensive burn. So all of these could have raised D-dimers. With that being said, the article also had clinical situations resulting in a false negative D-dimer. So in situations like that, we should also be cautious. They are small thrombus, time lag between symptom onset and laboratory testing, if there was a big time gap, and concomitant anticoagulation use with like heparin or warfarin. So these are, I'm not very sure if this table is important, but I feel like this should come in hand, this part. So yeah, just remember these. But what I know is this and this are very, very important for AMC. This chart alone could help you a lot when solving questions. So I try to put that in step order to remember. So if it's easier for you, try to remember this way. But if you are more of a flowchart person, then straight away remember it out of the guidelines. So that would be the diagnostic approach, I would say, for our DVT. Now let's go and see what we would do after we confirm that it is DVT. So once DVT is confirmed, I would say the mainstay of management is that the main goal is to prevent pulmonary embolism and clot extension and reoccurrence. And We would also want to prevent PTSS post-thrombotic syndrome. So actually, if I would say the most important things to remember is pulmonary embolism and post-thrombotic syndrome. Those two are very common complications when it comes to DVT. So these should be our main goals in managing. And yeah, the initial treatment for DVT, it often begins with low molecular weight heparin. Like we got to go for anticoagulation with low molecular weight heparin. And then like a transition to either warfarin or direct oral anticoagulant should be good. This is what the guidelines have directly said. So again, the duration of therapy, it depends on the cause. So if it's like a provoked proximal DVT, like let's say it's after a surgery, it's a provoked proximal DVT. The duration would be about 3 months. And if it's like an unprovoked proximal DVT, you could have extended treatment or like even up to lifelong therapy. And then if it's like a distal symptomatic DVT, usually 6 weeks to 3 months should be good. And apart from that, things that you should also know, you could include adjuvant therapy measures like compression stockings, early mobilization, maintaining weight, and controlling smoking. So those are the other things in management principles when it comes to DVT. So the main things I would say that you would want to remember in this is the initial therapy, because it's very common in AMC. That's something they would commonly ask. Just get familiarized with saying this when it comes to DVT. And the duration, I would say. Yeah, that should be the most important ones when it comes to DVT management. And then there's this pregnancy and DVT that we will talk when we are doing obstetrics. So for now, this should be good. With that, we'll just go to complications and follow-up of DVT as well. Like I said earlier, there are two major complications that we have to remember. One is pulmonary embolism. It's a very common one. It occurs in up to 50% if you don't treat it right. And then we also have post-thrombotic syndrome, where you can have like, you could see pain, like a chronic pain, edema, swelling, and venous ulcers. And it affects about like roughly 10% of patients within 5 years. So these two are the most important complications that we have to know. So the other complication, I would say it's complication that we would want to know is the reoccurrence of venous thromboembolism. It's another concern. So, like, there is a reoccurrence rate of about 16 to 17% after the first unprovoked DVT within the 2 years, according to these guidelines. So, like we just discussed before, the prevention could be compression therapy, lifestyle modifications like follow-up, weight control, monitoring for bleeding on anticoagulation, screening for underlying malignancies if the DVT is idiopathic. So those are some of the things that you could do as prevention. It's always good to know some preventive measures when it comes to DVT. So yes, that should cover the main points of DVT from the guidelines. And if we were to summarize it all into a little slide, let's say, yeah. I would say it's a DVT is like a very common and often missed uh, diagnosis. There's a very structured algorithm, like you saw before, like we discussed before, and knowing the risk factors, like we had to know this modified well score. It's very important. Knowing the risk factors and objective testing would guide you to the accurate diagnosis. And also, like I said before, it's not only about the clinical diagnosis alone. You got to do testing, got to do imaging. So it's very important. It's a combination of D-dimers and ultrasound. Those are the ones that's used for this diagnosis. And remember that anticoagulation is the cornerstone treatment. I'm sorry. Anticoagulation is the cornerstone treatment when it comes to DVT. And the duration, like we spoke before, it's based on whether the DVT was provoked or unprovoked. So it's very important to know the type of DVT. And we got to be aware of the complications, which we just discussed. It's pulmonary embolism and post thrombotic syndrome. That's very important to know. And it's the prevention. And yeah, I feel like AMC questions, they focus on the risk assessment and the diagnostic pathway and the treatment duration in DVT mainly. So if you can just know those tables and the little points that we discussed, you should be good to go with DVT questions. So yes, I feel like that's pretty much it about DVT, but then always space for more reading, more questions. And let's just do this question. Just a simple one. A 62-year-old man, 2 days post hip replacement, develops leg swelling and tenderness. Which is the most appropriate next step? So the answers are compression stockings only, order a D-dimer test, start low molecular weight heparin immediately, wait 48 hours for ultrasound, no action needed. If you all can pop in your answers, it's just a short question. This is the thing about trying to do recalls, unlike Amadex questions and AMC handbook ones. Most of the questions I took from recalls just to give an idea of what sort of questions that you all get in AMC. So recalls are recalled by candidates, so they're not very completed, but this is basically like the basic idea of what the question must have asked. So a 62-year-old man, 2 days post hip replacement, develops left leg swelling and tenderness, which is the most appropriate next step. Any answers? Okay, so with the discussion we just had, I would just say, like, this is a, I mean, this is a high risk. This, I remember I said about the hip replacement. It's something you have to remember in DVT. So this is a high risk. And I would also call this a provoked DVT because that there's a recent major surgery, like with clear DVT symptoms, left leg swelling, tenderness. So I would say a D-dimer test wouldn't be helpful here because remember we just discussed the D-dimer elevated other conditions like post-operatively it could be elevated. So D-dimer testing would not be very helpful here because post-operatively it will be elevated regardless of clot presence. So I wouldn't go for that. I mean, with imaging, I mean, you can confirm the diagnosis later with imaging, but treatment should not be delayed here. So I feel like preventing pulmonary embolism should take priority in a situation like this. With that being said, the question might not be very completed, so I would say I would just go for start low molecular weight heparin. Yes, because like I said, it's a high risk post-op orthopedic surgery and it's a unilateral swelling and empiric anticoagulation should begin immediately to prevent pulmonary embolism while waiting to confirm the diagnosis. And like we discussed, D-dimer is not useful post-surgery due to false positive. We just discussed it. It's directly out of the guidelines. So as you can see, if you are at least familiar with the guidelines, you would have an idea when it comes to AMC questions. So try to stay with guidelines as much as you can. So yeah, we do have another question. Let's try to do that as well. So in here, we have a 48-year-old woman on oral contraceptive pills, has distal DVT, confirmed on ultrasound, and otherwise healthy. What is the most appropriate management? No treatment. Repeat ultrasound in 1 week. Or we have anticoagulation for 6 weeks. And we also have anticoagulation for 3 months, anticoagulation for 12 months, and lifelong anticoagulation. So this is a bit of a challenging one, I would say, because these are the sort of AMC questions. I mean, the earlier one was a pretty straightforward one. It wouldn't come maybe that way. I mean, there would be questions like that, obviously, but these are the ones that try to take most of our time because of thinking that we have to make. So this is a distal DVT. We just spoke about this in our management. We just said the duration depends on the type of DVT. So this is a distal DVT. So what would this be? Any answers? I would just go for 3 months because that's because of the word distal DVT. Let me just double check it with this. Yeah, it's 6 weeks to 3 months. And I would just say, I know the answer 6 weeks is there as well, but when it comes to questions like that, it's always best to stay in the upper border. If something says 6 weeks to 3 months, and both of them are in answers, in AMC, what they expect is the upper border most of the time. So just go with anticoagulation, I hope. Yeah, anticoagulation for three months because it's a symptomatic DVT in a low risk woman who is on OCP. That was discussed in the risk table. So the best would be treating with the anticoagulation for nearly 3 months because shorter courses, short as in like 6 weeks of a course, can carry a higher risk of reoccurrence, and longer courses are obviously better. I mean, it's it's more preventable when it comes to recurrence. So I would go with 3 months for this question, mainly because when I see it still, I would just remove all the other answers and I would stick to this because I mean, we would remember it from the guidelines. And out of that, also, I would always go for the upper border to stay on the safe side when it comes to MC answering. So that would be the end of DVT for today. And yeah, pulmonary embolism should be my last topic for the day. Since it's quite late for me here, I am trying to do, I will do the pulmonary embolism topic and we'll see how much we can finish for today. So yeah, we have pulmonary embolism. Yeah. So pulmonary embolism happens when a thrombus, like typically from a deep vein thrombosis in the leg, travels to your pulmonary arterial tree and it could block the blood flow. That is basically what happens. And it is not, I wouldn't say it's rare because there's about 0.5 to 1 per thousand per year, and that's rising with age. And if there's an untreated pulmonary embolism, the mortality could go up to 30%, which is quite high. And yeah, this is, I mean, beyond the acute phase, there's could be long-term complications such as like chronic complications such as chronic thromboembolic pulmonary hypertension or even right heart failure. So there could be chronic complications as well. So I feel like AMC, I mean, pulmonary embolism is a very high yield AMC topic, and the acute management is very tested topic in the past. So let's try to finish this off as well. And this also I got from RSAGP guidelines. Before I forget, let me share it on the chat. That is pulmonary embolism. This is what I used. I shared it on the chat. So let's try to just go through this, and this is all from the guidelines I used. Guidelines had a pretty much good explanation and some charts and everything that I've used in the lecture. So let's get to this and finish off pulmonary embolism. So it like we said before, pulmonary embolism occurs when a thrombus, like typically from a deep vein thrombosis in the leg, travels to the pulmonary tree and all of that. So, when considering pulmonary embolism, we must think of the risk factors. These risk factors are directly from the guidelines, and I would say it's very, very important to know these risk factors by heart. Um, Major surgery, like joint surgery, lower limb surgery, abdominal or pelvic surgery, or cancer, surgery of cancer, or any major gastrointestinal tract surgery, or any multiple trauma, spinal cord injury with paralysis. So, any of these would be a risk uh, for pulmonary embolism. And if there's any acute or chronic medical illnesses like chronic heart failure, myocardial infarction, inflammatory bowel diseases, active rheumatic disease, nephrotic syndrome, acute respiratory failure, chronic lung disease, any acute or chronic medical illnesses, they could also be risk factors for pulmonary embolism. And apart from that, we also have malignancy related factors. We would put active malignancy as a risk, myeloproliferative neoplasms, or if the patient is on any cancer treatment, that could also be risky. And then we have hormonal related factors like pregnancy or early postpartum, or using oral contraceptive pills, or if the patient is on hormonal replacement therapy, that's again in the risk factor. And then if the patient has known thrombophilia, that comes under risk factors as well. And we have other risks like BMI being more than 30, and then venous stasis, varicose veins, having a past history of deep vein thrombosis or pulmonary embolism, or due to prolonged immobilization and travel. So this is very important. Like I said, the questions appear with a risk in the stem, so it's very important to know this. And that's again straight away from the guidelines. So let's talk a little bit about the pathophysiology, as in it's not directly pathophysiology. This is the virtuous triad that you should know when it comes to pulmonary embolism, because they directly present in the question stem. Just remember the virtuous triad for pulmonary embolism, like venous stasis, endothelial injury, and hypercoagulability. So knowing these could help you spot a patient when a patient is at high risk, and you could consider pulmonary embolism in your differential diagnosis, which helps you find the right answer in the exam. So yeah, that is a quick summary about the risk factors and pathophysiology. We'll now discuss the clinical presentation and the red flags that we should know. So I would say the symptoms of pulmonary embolism can be very subtle or like very dramatic. So you could see like sudden dyspnea, sudden breathlessness could be there, and the pleuritic chest pain, and sometimes there could be hemoptysis and syncope. And I feel like on examination findings, you could see tachycardia, hypoxic, that's oxygen desaturation. And then also you could see unilateral leg swelling, the leg signs of DVT. So yeah, and yeah, something you could remember is that if the right ventricle is strained, you could see jugular vein distension, hypotension, BP low, and that is some of the signs that you would notice in pulmonary embolism. And the red flags that you would want to know, identify true emergencies is, I mean, for pulmonary embolism, it would be hypotension, where the systolic blood pressure is below 90. And then we also have signs of shock and cardiac arrest. This is when we can realize that this is a true emergency and we got to act accordingly. So the red flags are important, the clinical findings are important, and the examination findings are important as well. That is the basic, the common, the most known pulmonary embolism symptoms, I would say. And now let's discuss the diagnostic strategy and algorithm. So there's in AMC we follow a structured algorithm, like a just like DVT. This also has a chart that would make it things easier for you. So I would say we could just follow the chart just like that. It's very similar. So what we do is we assess the well score. Again, this well score is based on clinical features like that. So if there's clinical signs and symptoms of DVT, you get 3 points. And if there's pulmonary embolism, most likely, if pulmonary embolism is most likely diagnosis, you get 3 points. And then if the heart rate is more than 100, you get 1.5. And if there was immobilization for at least 3 days or like if there's a surgery in the past 4 weeks, again you get 1.5 points. And then if there was previous DVT or pulmonary embolism, you get 1.5 point. If hemoptysis is there, you get 1 point. And if there's malignancy treatment within 6 months or palliative, you get 1 point again. So in here, what happens is if the well score is more than 4, if it's more than 4, you would want to go for imaging. Anything 4 or less should be low risk. So this is the well score criteria, but don't. There's another well score that's a modified one, which we came across when it comes to deep vein thrombosis. It's different from that, so don't try to mix those up. Like I said, the best is to keep coming back to these guidelines. That way you will remember it. So yeah, that should be that. The well score for P is the most used one, more than this perk rule. We'll come there. We find it in the diagnostic algorithm, but this is more important. So when you get a clinical suspicion for pulmonary embolism, we would apply the well score, the simplified well score, and then like we discussed, if the points are less than 4, like 4 or less, it's a low risk. Then we apply the perk rule. So what that is if the patient is below 50, if the pulse is less than 100 beats per minute, if the oxygen saturation is more than 95 or more, if there's no hemoptysis, if there's no estrogen use, if there's no surgery or trauma requiring hospitalization within 4 weeks, and if there's no prior venous thromboembolism, if there's no unilateral leg swelling, that is when we apply the perk rule. And if the perk rule is negative, we could safely exclude pulmonary embolism. But if the perk rule is positive, we would go for a D-dimer test next. And in that case, if the D-dimer test is negative now, then we exclude pulmonary embolism. So in DVT, we divided it to likely, less likely, and we remembered imaging and D-dimer. And for the other one, D-dimer imaging. In this one, just one way. It's you go for Bell score, go for PER, then D-dimer, and if it's negative, it's excluded. If it's positive, then you go for imaging. With that being said, the high risks are very easy. If the Bell score is more than 4, you straight away go. If you categorize the patient as a high risk patient, and you straight away go for imaging. So that would pretty much be the diagnostic algorithm, I would say. And in pulmonary embolism, something that we have to know is that CTPA is preferred. If they're asking the most preferred, the best, the first hand, the first choice, or anything of that sort, we would choose CTPA. But there are situations where VQ scanning is where we have to choose VQ scanning. It's pretty much related with obstetrics, and we will come there when we are doing that topic and discuss it with that. But for now, just remember that CT pulmonary angiography, CTPA, is the go-to image when it comes to pulmonary embolism. It's the most high yield, it's the best one that you could choose. So just remember that when it comes to pulmonary embolism. And yeah, we could go to now risk and management pathway. So once you have diagnosed pulmonary embolism, you should properly stratify the risk and then decide how to manage accordingly, pretty much the same way we did in the previous diseases, previous conditions as well. So low risk patients, they could be managed outpatients in some situations. So I would say low risk patients would be managed outpatient. It's possible. And then there's intermediate risk patients where they may need hospital admission and they monitor their functions. So that is for intermediate risk. And then high risk, like massive risk patients, they would need immediate reperfusion. They would need immediate thrombolysis. So thrombolysis or like a surgical embolectomy. So that is what these RSGP guidelines emphasizes. So simply the hemodynamical instability is the one that triggers what the action should be, how urgent the action should be. So I would just say for management, always begin with anticoagulation unless the patient is strongly contraindicated for that. Yeah, and consider thrombolysis, thromboembolectomy if the pulmonary embolism is massive, and monitor and treat right heart strain. So those are some of the important things that you have to know in management of pulmonary embolism. So I would say like the backbone of pulmonary embolism management is anticoagulation. So you start with low molecular weight heparin or unfractionated heparin if needed, and then you could then transition to either direct oral anticoagulant such as rivaroxaban or apixaban, or you could just give warfarin. You got to target the INR for it to be between. Let me write that INR to be between 2 to 3. So yeah, and the provoked pulmonary embolism, like a surgery, would be typically 3 months, and longer would for unprovoked ones, or if the risk is persistent, if there's an ongoing risk. And then we have advanced therapies like thrombolysis, thrombolectomy, IVC filters. So that should be definitely reserved for patients who are with absolute contraindications for anticoagulation. So we do have advanced therapies as such. So that should cover the treatment and management options for pulmonary embolism. Let's now quickly run through the follow-ups, the complications and the prevention that we should know. So after any acute phase, a follow-up is very critical because patients are at high risk, like patients are at risk of the recurrent venous thromboembolism. It's a rare but serious complication, I would say. I mean, the chronic thromboembolic pulmonary hypertension is a rare but a serious complication. So it's good to be in the watch for these two complications. And like we already know, the preventive measures would be to address the risk factors we discussed. It's the best way to remember preventions. Just know the risk factors and know that we got to address them: the immobility, the obesity, the oral contraceptive pills, and the prophylaxis in hospital and after surgery, like compression, anticoagulation. All of these things could come under prevention. Uh, yeah, and I believe that for AMC pulmonary embolism, they expect questions like they ask questions both on acute management and follow-up preventive steps. So this part is something that you cannot just leave behind when it comes to AMC preparation. So it's good to know that. And then the key points that we need to know in pulmonary embolism, I would say, is always assess pre-test probability first. The Well score is a must. It's very important to know that. And we have D-dimer for low probability cases, and CTPA for imaging. In most of the cases, CTPA is very, very important when it comes to pulmonary embolism. And you have to stratify the risk factors, the risk, that is what determines the urgency of therapy, the urgency and the therapy type. And like I mentioned before, anticoagulation is the cornerstone, and the duration depends on the cause. So we also need to watch for long-term complications, like we just discussed, VTEN, CTEPH. That's something you need to know. So that should pretty much cover the key points for this pulmonary embolism. Now let's just do this question. So it's a 55-year-old man presents with sudden onset of breathlessness, pleuritic chest pain, and a heart rate of 110 beats per minute. He had knee replacement surgery 2 days ago. His well score suggests moderate probability. D-dimer is elevated, which is the most appropriate next step. So they're asking the most appropriate next step. Be very mindful when deciding the next step, because some of these tests could be useless given the symptoms. So it's very important to know. If you could just pop up the answer on the chat, it would be great. The answers are reassure and discharge home, order D-dimer again in 24 hours, proceed to CTPA, begin warfarin without imaging, and insert IVC filter. In this, I would say uh, this is like a classic example of a uh, probability of having a high D dimer, elevated D dimer. So, as the guideline says, I think we are safe to move to CTPA rather than waiting or delaying because they're asking the most appropriate next step. Yeah, it is proceed to CTPA because with the moderate probability and the elevated D dimer, CTPA should be the required to confirm the diagnosis of pulmonary embolism. I mean, it's not a case to reassure and delay, and also warfarin without imaging is insufficient. And like we discussed earlier, these alternative methods like IVC filter it's only indicated when anticoagulation is contraindicated. So if they're asking the next step, I think it's pretty safe for us to choose CTPA as the guideline says. So yeah, let's just discuss this question as well. That should be the last question for today. A 68-year-old woman presents with sudden collapse, hypotension, BP is 80/50, tachycardia, and right ventricular dilatation on echocardiogram. She has no recent surgery but has active cancer. What is the most appropriate management? Start low dose aspirin and observe. Begin direct oral anticoagulation, rivaroxaban, and discharge home. Initiate anticoagulation only and monitor. Systemic thrombolysis followed by anticoagulation. Insert IVC filter and no anticoagulation. So in this we have a hypertension patient. What would the answer be? Appropriate management, they're asking. This is why we have to be very mindful about what they're asking. It's not the next step, it's not about any diagnosis they're asking, but it's appropriate, most appropriate they're asking. So the answers. I think in this we have to go with thrombolysis, uh, followed by anticoagulation, because this is a massive risk patient. It's a high risk pulmonary embolism. She's hypertensive. She has a right ventricular dysfunction. So we just discussed in the RSCGP guidelines that it's saying that hemodynamically unstable patients, like we should initiate thrombolysis um, immediately. followed by anticoagulation. So it should be systemic thrombolysis followed by anticoagulation. This is a high risk patient, and just like we mentioned, she has right ventricular dysfunction, and we forgot to highlight that as well, the active malignancy that's going on. So all of that combined is a high risk patient. So this indicates, the guidelines indicate that in a massive pulmonary embolism with hemodynamically instability, reperfusion therapy is indicated immediately, and it should be followed by anticoagulation. So direct oral anticoagulation alone or observation is inadequate, like in the other options, and IVC fields alone without anticoagulation is only for contraindicated conditions for anticoagulation, just like we spoke in the earlier question. So I think the most suitable answer for this would be, because they're asking for the most appropriate management, the most suitable answer should be the systemic thrombolysis followed by anticoagulation. So yeah, that is the last question I think I added for today. I feel like we had a pretty deep discussion compared to the last Tuesday's class, because these topics that we discussed are very repetitively asked questions in AMC. And if you'd already tried to do AMADEX, the cardiology part of AMADEX, you might have realized that there's a there's a there's quite a bit of questions coming from vascular, and you can't be waiting until you do surgery to prove that, because it's in the cardiology part in AMADEX. It's one of the reasons which is better to finish the vascular part along with cardiology when you are doing it. And try to do the handbook questions as well. It's very important. And if you can also find M plus X or any other Q banks, try to do as many as questions as you can. And I know the answers are given in Q banks, in handbook and everything, but try to find your own answer. Try to just, and now I've showed you all how to find your answer from the Google, by typing the topic you want, just pulmonary embolism, RSCGP, and read some of the articles that come up. You should probably be able to find a answer for your question. So that should be pretty much it from the vascular topic for today. I think I added a little link for you all to read varicose veins. It should be here. Yes, that is something I came across for varicose veins. I mean, varicose veins, it's not a very, what you say, deeply asked question. It'll be helpful to as a differential diagnosis. Yeah, you could just have a quick read through that. I'll share the varicose vein link as well. So try to have a quick read. So yeah, try to save, since this chat is going to disappear, try to save all the guidelines I sent. And I think I shared this slide earlier as well. I would call this my weekly to-do list, just to read the John montage, read RSAGP guidelines for anything unsure, especially for topics like this. I would say just follow guidelines and do AMC handbook for the cardiology questions, do the AMADEX one. Make sure, now tomorrow is Sunday, make sure you try to finish cardiology doubts within this week. I mean, you should be ready with your little notes, with questions and all that. And I think I mentioned this website earlier as well, the med bullets for any major topic like valvular heart diseases or anything, even for vascular the parts, if you're finding anything um, complex to read long guidelines, just type on med bullets. It gives you a very summarized note, already ready-made note where you can just maybe print out and study. So med bullets is a very useful resource. And I think I said this before, I'm saying this again. Share your doubts on the WhatsApp group. We'll try to keep it as active as possible. I mean, for that, you all have to bring in questions. We'll try to share questions as well. So that way we could have a good discussion and share each other's resources among us. And I think everybody will benefit from it. So try to share your doubts on the WhatsApp group. And if you haven't joined the WhatsApp group, I think Dr. Sanjay has shared it on the WhatsApp chat earlier. Yeah. So yes, that's a pretty basic and explanation from the left out topics from cardiovascular disease, cardiology from last week. So I was initially planning to do some questions, but I thought we should do these left out topics so our question class will be more efficient and more useful. But with that being said, I would also want to say that the question class, along while doing questions, we'll try to find any doubts along the way, try to search on John Muttaj and RSCJP. So for today, thank you so much for joining in. I hope you all are working on cardiology and good luck with that. And we'll meet you all again in the question class, and we will announce the question class date on the WhatsApp group. So just stay alert for the messages. So I hope you all have a great evening. Thanks for joining.